Hey, good afternoon. My name is Frank. I will be presenting on the difficulties of terminal prognosis. Um, it is in regards to the Oregon law, the law in the Oregon state, which regards to the fact that if somebody is considered terminally ill, then they would need, if they want to die and they decide to go this route instead of treatment, they would need to request the approval of two physicians. They have to both declare that the person is, in fact, terminally ill and they have less than 6 months to live, and that it is incurable and untreatable. So under these regulations, somebody who is from the Oregon state is allowed to participate in this type of treatment. This was a new uh, type of situation that the medical field has walked into in the late 90s, and it did create a lot of uproar, a lot of people considering it immoral, a lot of people considering it very much moral, and it depends on how you look at it. And just before we get too deep into it, I want to just note a couple of things that should be questioned before this can be looked at in an unbiased method. So when I was watching the video of Dr. Atul Gawande, he was asking a couple of interesting questions. The first that I noted was, what are the patient's priorities? And when you're, as a nurse especially, and when you're working in the medical field, you plan a goal that is attainable. But one thing that matches there is the patient wants this goal as well. Yes, they're there to be treated and to feel better, to be healed, cured, or treated. But in the case of death, it becomes a little bit harder to decipher if that's something that's valid to do. So where the patient's priorities could entail that the patient prioritizes death over living. One of the things that I found interesting is that they brought up the quality over quantity of life. Is having 6 months of living that are painful, regrettable, just a few 6 months that you don't want to live, is that quantity of lifetime better than the quality that you're having, and which one would outweigh the other for the person? And it may differ per patient. What is their minimum quality worth living? Somebody could be very appreciative if they could just sit on a couch, watch their games, or watch whatever they want to watch, sit with their family, even if they can't do it all the time. If these are things that they find valuable and worth living as far as they can live, then they might consider staying alive and going through this process. If they can't achieve those minimum qualities of life that they are weighing out themselves, then they might consider, well, it's better that they die now than live these 6 months that are not meeting the qualities that they consider worth living. A couple other things would be, what do you understand your prognosis to be? Do they understand what their condition is, what's going on with them? Because that would really put a big difference on what they would consider as well. Their biggest fears and their concerns in regards to it, the goals that are most important to the patient, and what trade-offs are they willing to make, and which ones are they not willing to make. And the last question was, how do you want to spend your time if your health worsens? So in regards to the medical field, they also considered the financial part of it. And that was that 25% of medical fund was spent on the end of life, and often their life still worsened. So in 1978, the funds were 28.3% in the United States. In 2006, it was 25.1%, so it dropped a little bit less in the financial aspect. And so after that, I started looking at the article with Cardinal Vincent Nichols, and they were looking at this baby who was just about two years old, just reaching 2, and he was in a vegetative state for about 18 months, where the hospital and medical staff were treating and trying to figure out what's going on so that we can take care of him and get this baby out of this situation. Well, after 18 months, to no avail, they did not reach that. So the baby was at that time still under a vegetative state. The parents wanted to move the baby out of this specific hospital to a hospital in Rome. They tried to reach to the cardinal, and the church, after reviewing extensively the situation, the case of this baby, they decided that the hospital was in fact doing the best they could, even though they were stating that the baby is untreatable and incurable. So in this scenario, the baby is terminally ill. The parents, obviously being subjective because that is their child, want to do everything they could to make sure that the baby survives and can have this opportunity to a life. But the church itself also thought that it might have been the entire medical establishment was not in the child's. The opinion was that not in the child's best. It was not in the child's best interest to prolong extraordinary and futile treatment, which they cannot help. And the church did inevitably agree with them. So they did praise the parents for trying as hard as they could to make sure that the baby did survive, but the baby did end up passing away several days before its second birthday. So in regards to the difficulties of the terminal prognosis, it's a hard decision to make, but I believe that it may weigh closer to that it might be immoral to consider if someone should be able to go through euthanization, because as a provider, you are an expert of your work and you may be seeing the data, but you would never know how long somebody actually has to live. And there's proof on that there's in 2016 there was 90 patients that were prescribed the drug for euthanization that did not take it. And of the 90 died, 36 of them died. So 40% of this group of patients in Oregon did pass away. 60% survived the expected timeline that they were expected to die at. And then at a national level, there was about 900 eligible for hospice because they were prepared to die in 6 months, and 70% of them lived longer. Also, there was a case where they were expressing that in nursing homes, if you have dogs or other animals, pets, it gives you a sense of responsibility, some companionship, love, something that someone that you can appreciate next to you and spend time with. And that also increased the survival rate of these patients, and also the less amount of they reduced the amount of drugs that were needed for them as well. So with that information, and that's just one example, I believe that perspective is very important in this scenario because it's hard to remove yourself from biases. And as a provider, when you're speaking to your patients, or as a nurse, when you're speaking to your patients, you have to be very cautious on how you speak because you do not want to give them the wrong impression. You don't want to give them a negative tone. And that may be very difficult in a scenario where, in fact, the person may be terminally ill. But there should be a technique, a strategy to make sure that the person has faith, has hope in their condition and their situation. And sometimes it could be much more difficult than expected. Especially if somebody is already in different type of mental conditions, or mental conditions arises, or if they're in some state of depression, and then they receive these news of a terminal illness, it could almost be inevitable that they might want to die versus live and not give that opportunity. But as a provider, you should be explaining the scenarios and explaining why each one could result to a specific outcome, and then have them, maybe consider their families if they have family, because not everybody does. But it's important to simply just establish that rapport and make sure that you give them that sense of hope and faith so that they are not so quick to make this decision, but to really, if they think that this is the scenario that they should, they're going to really think about it in which they probably would be in any scenario, but it would just give them some more of an outlet of hope in their scenario. A lot of people who chose to die wanted to because they felt that they had no reason to live anymore, their quality of life, like I mentioned earlier. Um, so if there's something that gives them quality, something that gives them a reason to live, even though they're in this certain scenario, they may not want that. But if they feel like they have nothing to live for, then they may be okay to do that. Um, in my scenario, I would hypothetically, because I'm not thankfully in that scenario, I would hope that I have the perspective to at least have the hope that I will live longer than the 6 months, and that maybe I can, maybe there's something that's waiting for me after this time, from here to 6 months. Um, so it would be more about the unknown to me, where since I'm not sure what will come, I can't just take somebody's word for it. And if my doctor is telling me, and even if I have faith and trust in my doctor, he's telling me or she's telling me that I have 6 months to live and it's incurable and untreatable, then a prognosis may be beneficial so that I have a better quality in that time frame where I'm not feeling the pain of my condition, even though it might shorten or guarantee the 6 month time frame. Maybe that's the route that I would take if I feel that there is nothing else that can be done for me. But I would not try to just uh, end it there. I would like to see where things go, because you just simply never know where life can take you, even in these moments where you think everything is done. And it's difficult to express that and have that conversation with the patient, because you don't want to give them an answer. You want them to really come with their own answer, but you want to help them reach that without being biased or subjective. So in my case, like I said, I think that they should not allow physician-assisted suicides. I think that it is very difficult to manage the criterias within that to make sure that you are actually providing appropriate care for those people who need it. Okay. Thank you.